And I want to thank everybody for coming to the reinitiation of Grand Rounds. I want to thank Sam and Nicole from Zoll for sponsoring the talk today, and really a big thanks to Mark Lowry for all the work that she does to put these talks together and everything. Today we're going to be talking about stroke prevention in patients with AFib, which is a common thing that we practice. These are my disclosures. I think that this is a helpful framework to approach your patients with when talking to them about AFib and when trying to manage their AFib. And I like to think of it in three silos of treatment. One is improving their symptoms, and that includes things like antiarrhythmic medications and some of the fancier things that we do like ablation. Preventing strokes, which is what we're going to be talking about today, and then addressing risk factors that can contribute both to AFib and to stroke. And as you can see from this chart that I put together, they do overlap to some degree. I think it's helpful to think of them as separate issues. I think the degree to which they overlap is changing with time and probably increasing. But it's helpful to think of stroke prevention as a separate entity. If you haven't read the 2019 update to the AFib guidelines, I would encourage you to at least look at it. It's a fairly short document that goes over a few meaningful changes over the 2014 guidelines. And one of the most useful things that they did in this set of guidelines is in the very first paragraph, they decrease some of the confusion about what it means to say non-valvular atrial fibrillation. Because I think cardiologists and electrophysiologists have struggled with how do we classify patients as having valvular or non-valvular AFib. And they simplified it for everyone. And the consensus now is that valvular AFib refers to patients with either moderate or severe mitral stenosis. Usually those are patients who are being evaluated for mitral valve replacement or repair, or patients with mechanical heart valves. And that's important because in those patients, the only acceptable stroke prevention strategy is warfarin.
Is it under KPI reporting or is it under provider application?
Can I ask you guys to please mute your devices? Thank you. And any patients who don't have moderate or severe mitral stenosis or mechanical heart valves is considered to have non-valvular AFib. And I listed these items because I think they're useful to remember that patients with even mild mitral stenosis or any degree of mitral regurgitation, any sort of aortic stenosis or regurgitation, those are not patients with valvular AFib. Those are considered non-valvular. One of the big question marks we have in our field is what to do with patients with bioprosthetic valves or valve repair. And there are enough patients in these clinical trials that have had at least bioprosthetic valves to suggest that valves are safe and effective in those patients. These are some of the important class 1 indication points that they make in these new guidelines. And the first is that the use of anticoagulation in these patients should be part of a shared decision-making process. And it's hard to imagine a better example of shared decision-making than the use of anticoagulants. These are medications that have two relatively identifiable endpoints in stroke and bleeding. And there's plenty of fear in both of those endpoints in the patient's mind when they come to see you. So it's a great example of including the patients in the decision-making process. Importantly, the CHADS Vas Score is now the preferred risk score for stroke risk prediction, and we'll go through how to calculate that. Any patients with 2 or more points on that CHADS Vas Score, in the case of females, it's 3 or more points, should receive or at least be considered for anticoagulant use. And then one of the big things they emphasize in the newer guidelines is that the stroke prevention strategy that you decide upon should really be independent of the type of AFib that the patient has. That means whether they have paroxysmal or permanent atrial fibrillation, your stroke prevention strategy should not change. And I use this figure as an example that I've had for a number of years of a patient who has a pacemaker. And you can see that they record how much AFib the patient's having. And this particular patient had a stroke in the middle of weeks of normal sinus rhythm. And so we really try to be proactive in preventing strokes in a primary prevention type manner with patients with AFib. And then lastly, atrial flutter is roughly equivalent to atrial fibrillation for stroke risk, and the same concepts that we use for atrial fibrillation can be applied to atrial flutter. Why do patients with AFib have strokes? Well, Virchow a century ago described his triad of thrombus formation that includes stasis of blood, endothelial dysfunction, and hypercoagulable state. And it's certain that there is decreased flow in the left atrium and left atrial appendage during atrial fibrillation. And there are a host of inflammatory markers that are expressed at higher levels in patients with atrial fibrillation. It's certainly much more complicated than that. We now know that there are oxidative stress markers that go up during atrial fibrillation, and there's some new evidence that the membrane potential that changes during AFib may be involved in platelet activation in those patients. And the net result, as we see in this figure here, is thrombus formation in the left atrial appendage that leads to stroke. And then please remember that patients with AFib can have strokes for other reasons. Like any other patient, they can have atherosclerosis in the carotids or the aorta, and they can have other emboli that lead to strokes. The most useful tool we have at stroke prediction is the CHADS Vas Score. And I really wanted to emphasize that this should replace the formerly used CHADS score, because the CHADS Vas Score expands the number of patients that are considered appropriate for anticoagulation. I've listed the components of the CHADS Vas Score on the right, and that includes congestive heart failure, hypertension, age. You get 1 point for being 65, 2 points for being 75 or older. Stroke is 2 points. And then just to point out that female gender is now considered a risk factor. It's the least potent of these risk factors. So in females with 1 or 0 other risk factors, we consider those patients to be very low risk. The female gender risk factor really becomes an important risk factor when the patients are over 75 years old. The panel I have listed down here includes the prior recommendations for anticoagulation based on CHADS Vas Score. And we now know that if you have no risk factors, your risk of stroke is very low, and anticoagulation can potentially be avoided. The other thing I want to point out is aspirin really has turned out to not play an important role in stroke prevention. The data that we used for aspirin is now over 30 years old and was pretty puny to begin with. The new guidelines don't even mention aspirin as a mechanism to prevent stroke. So it really comes down to anticoagulants versus no anticoagulants. And the magic number in the CHADS Vas Score is 2 or greater. 3 or greater if female gender is one of those. The Hasbled score is the converse of that and can be used to estimate the patient's risk of bleeding. A lot of the components of the Hasbled score, which are listed here on the left, are the same components in the CHADS Vas Score, which is surprising to patients that the same risk factors that predict stroke also predict bleeding. The things I want to point out at the bottom of this panel, drugs or alcohol, includes agents that can promote bleeding, such as the use of aspirin or anticoagulants. This has been relatively poorly validated in a prospective manner. It was really designed in a retrospective analysis. but it is the most widely used and probably best predictive way of predicting someone's risk of bleeding on an anticoagulant. The one thing I want to point out is that we often weigh the Vas score against the Has-Blood score to say someone's risk of stroke versus risk of bleeding is higher, but I think we could argue that those are not equivalent events, and that most bleeding events are not life-threatening or fatal events. However, most strokes with atrial fibrillation tend to be severe debilitating strokes and can be life-changing for the patients. So even though the scores in the Has-Blood score and Vas score may be similar, we try to prevent strokes in a more aggressive manner than preventing bleeding. I think it's important to consider other risk factors for stroke that are not included in the Vas score. And we now are aware about some features, some morphologic features of the left atrial appendage that we'll talk about that may help predict stroke. We know that higher left atrial pressures are predictive of stroke. Sleep apnea is the Rodney Dangerfield of AFib. It never is thought about, but is very important in the genesis of AFib and as a predictor for stroke. And then things like family history, smoking, cancer to the extent that it is thrombophilic, and obesity are risk factors for stroke. Obstructive sleep apnea in particular is important. This was an analysis of more than 5,000 patients, and sleep apnea was the most potent predictor for stroke in the univariate and multivariate model. So it hasn't made it into a Vas score because it's not easily identified in a patient interview, and often patients are not diagnosed with sleep apnea. But because of this relationship, we do recommend that patients with AFib at least be screened for sleep apnea, and if they have sleep apnea, be treated for that. And I often consider that in my discussion with patients about stroke prevention as an additional risk factor for stroke. Not necessarily predictive of stroke, but predictive of left atrial appendage thrombus are these factors that I've listed. Some of them are the same as the Vas score. So reduced ejection fraction, elevated left atrial pressures, features of poor left atrial appendage systolic function, low velocities, low appendage ejection fraction. And now we know about some morphologic features of the left atrial appendage which are predictive of stroke. We know that the larger the orifice of the left atrial appendage, the higher the risk of stroke. There are certain shapes of the left atrial appendage that we now have the vocabulary to talk about. There's something called a chicken wing that has a relatively low risk of stroke compared to other shapes of the appendage. And these are things that have just come out in the last few years, and it really haven't made it into the stroke risk scores that we use. We know that thrombus is seen in a fair number of patients with acute AFib, even less than 3 days. And even some patients who've been on anticoagulation for more than a month can still have left appendage thrombus if they remain in atrial fibrillation. That's something that we consider when recommending cardioversion or ablation to patients. Warfarin, of course, is the previous gold standard. I don't think we can say it is anymore for stroke prevention. And all of the trials that looked at warfarin for stroke prevention have shown a significant decrease in stroke down to somewhere around 2% per year. And it depends a little bit on your underlying risk of stroke. I think 2% is a reasonable number to use when talking about to your patients about stroke prevention. It's definitely superior to placebo, and patients will often ask if aspirin is a reasonable alternative. Again, aspirin really, for most patients with AFib, does not play a role in stroke prevention. We don't really use it even in low-risk patients. And warfarin has somewhere around a 40% relative risk reduction in stroke prevention compared to aspirin. Of course, the problem with warfarin is the relatively narrow therapeutic window, somewhere between 2 and 3. Above that, the risk of bleeding goes up, and below that, the risk of stroke goes up. One of the fascinating things that we learned from the new anticoagulant trials is the fact that the time spent in that therapeutic window, the range between all those trials was between 58 and 62%. So that's a pretty consistent number that we've seen in the clinical trials. The numbers that we've had here at New Mexico Heart and Lovis are greater than 80%, so that's a testament to the skill of our clinic personnel. But there is a large number of patients that fall outside of that therapeutic window. The other problem with anticoagulants in general is that they're underused. So this is Medicare data looking at patient anticoagulant use based on their CHADS Vas Score. And just to orient you to this graph, the top panel is patients on no therapy whatsoever. The light gray panel are patients on aspirin only. And then the lower panels are some sort of anticoagulant use. And you can see that if we consider aspirin as really not an appropriate therapy for most patients, that only about 50% of patients, even at high risk of stroke, are on some sort of anticoagulant. The reason that they're on that may be patient preference, may be physician or provider driven, but we know that they're definitely underused. Even when they're prescribed, the adherence is best described as not good. When patients have a CHADS Vas Score of 2 or more, the adherence rates are only about 50%, both for the novel anticoagulants and for warfarin. They're a little bit better for the newer anticoagulants, as you can see on this bottom graph. The adherence rates in the red line are the newer anticoagulants. It is better than warfarin, but it's still fairly suboptimal. There's a lot of reasons for that. This is an example of physician-driven reasons for stopping anticoagulation. This is an evaluation of elderly patients in a nursing home, fairly old with a mean age of 87, high risk for stroke, CHADS Vas of 5, and only about 50% of them are on anticoagulants. One of the disturbing features of this is that one of the main reasons for discontinuing anticoagulation in these patients is the fact that they had paroxysmal atrial fibrillation. And really, that needs to be not an acceptable reason. Paroxysmal AFib has the same risk of stroke, potentially higher than patients with permanent atrial fibrillation. Falls is the leading reason in the elderly to discontinue anticoagulation. We know that the number needed to fall to create a serious event with anticoagulants is actually quite high. It's somewhere north of 20 for most patients. But we tend to, as a field, overestimate the importance of falls in terms of risk of bleeding. Most falls do not result in significant bleeding. If we look at pooled data for the anticoagulants versus warfarin, I listed the agents for each of these trials on the left. And these are the 4 main trials that have looked at the clinically available anticoagulants now. And we can see that most of them have superior prevention of stroke or arterial embolism. We forget about dabigatran. It's actually a fairly effective medication. It's more effective than the others when placed head-to-head against warfarin. It does have a fair number of side effects that can limit its use, but it is a suitable medication. So when patients come in on dabigatran, I tend to leave them on that because of its effectiveness. It has the same bleeding risk as warfarin, as you can see in the bottom panel. Apixaban and edoxaban both have lower bleeding risks than warfarin. The other thing about apixaban is it is the one agent out of these 4 agents that have shown a mortality benefit compared to warfarin. So if I were to pick one with no other influences involved, including cost to the patient, I think apixaban probably has the best safety and efficacy profile. If we look at just bleeding episodes, this is a slide that I just wanted to show some of the nuances of the bleeding risks of these agents. Apixaban has a lower bleeding risk compared to warfarin for all sorts of kinds of bleeds. Dabigatran has a lower intracranial hemorrhage risk. And rivaroxaban does have a slight higher risk of GI bleeding compared to warfarin. So if someone is having GI bleeding and they're on rivaroxaban, it may be reasonable. This is pooled data looking at the newer anticoagulants compared to warfarin, just to point out that a lot of their safety and efficacy are driven towards reducing hemorrhagic stroke. They do have a lower risk of intracranial hemorrhage. There is a slightly higher risk of GI bleeding, which is driven again primarily by rivaroxaban. The other ones do not have a higher risk of GI bleeding compared to warfarin. One of the common things that we see in clinic are questions from other providers that are working with the patient to do some sort of procedure or surgery. And how do we bridge these patients? When do we bridge them? This used to be a source of frustration for us because of the inconvenience of low molecular weight heparin. We found in this trial when we randomized patients who were on warfarin to either receive low molecular weight heparin versus placebo, is that bridging really didn't decrease the stroke risk, but it did increase bleeding. We've extrapolated this data now to use with the novel anticoagulants as well. So most of the time, the recommendations are not to bridge using whatever agent you're on, and just to hold either for 48 hours for the newer anticoagulants or 5 days if the patient's on warfarin, except patients who are at particularly high risk of stroke, someone with a recent stroke, someone who has a known left atrial appendage thrombus, someone who has valvular heart disease. Those would be patients that would definitely want to bridge. So let's talk about the left atrial appendage. So since this is thought to be the source of most strokes in guys, can I just remind you to turn off your A lot of patients ask us why they have a left atrial appendage, what use is it? And we know from embryology that the left atrial appendage is actually the left atrium, and that most of the adult human left atrium is actually pulmonary venous tissue, and that the embryologic left atrium is kind of, most of the embryologic left atrium is what's left over as the left atrial appendage. It's the trabeculated portion of the atrium. The rest of the atrium tends to be smooth walled. And most of the strokes we think come from the left atrial appendage. It's not fair to say that it does nothing useful. It does have some contractile function that we can objectively measure with ultrasound data. It's more compliant than the left atrium, and we think that it serves as a pressure release valve in states where the left atrial pressure goes up. That may reduce symptoms of dyspnea for the patients. It's involved in diuresis with natriuretic peptide that has some neurohormonal activity. And there is now some data that the left atrial appendage or structures surrounding the left atrial appendage may be involved in rhythmogenesis of atrial fibrillation itself. The data that we have that the left atrial appendage is the source of strokes in most patients is actually pretty old data. And if you look at the study from 1995, it was autopsy data in patients who had had a recent stroke. It's not a great way to estimate this, but we do still think that this holds true, that most strokes in patients with AFib come from the left atrial appendage. In the past 10 years or so, we've imaged a lot more of these appendages than we have in the past. And we now have a set of terms that we use to describe the shape and size of these appendages. And these are casts from 4 different styles of appendages. It's one of the most variable portions of human anatomy that we have. This is an example of what's called a chicken wing, where there's a primary left atrial appendage body with a secondary wing or room off of it. We have some data that this is associated with a lower risk of stroke than some of these other morphologies. Because it's the source of stroke in so many patients, there's a long history of removing this. This all started with surgery, and the surgeons have the advantage of being able to directly visualize the left atrial appendage. There's a host of ways that they can do this. The traditional way is to sew the ostium closed, and then often physically remove the appendage. One of the newer devices available is called the AtriClip device that can be easily put on the outside of the appendage. And this can be done as an adjunct to any type of open heart surgery that the patient's undergoing. One of the problems with analyzing the data of these techniques is that the follow-up data is not great, and the surgical techniques can vary from surgeon to surgeon. We do have some meta-analysis data that show that patients who undergo left atrial appendage closure, regardless of the type of surgery that they were having, they do have a lower risk of stroke in the first 30 days and lower risk of all-cause mortality. So typically when patients are undergoing heart surgery and they have a history of AFib, or if they're undergoing mitral valve surgery and they have a predictive chance of having AFib, we recommend some sort of surgical left atrial appendage closure or removal. A lot of these techniques can now be done percutaneously. The Watchman device is what we're going to focus on for the next couple of minutes because it's the only FDA-approved device in the United States. There are a host of other devices that are potentially coming down the pipeline, but this has really been the dominant device for the past 5 years. It's actually been around since 2006 when the first clinical trial was started. There are now two randomized clinical trials that we get our data from this device, the PROTECT AF trial and the PREVAIL trial. And we're not going to go into all the nuts and bolts of these trials, but the PROTECT AF trial was the initial trial. There were some questions that the FDA had about safety of the procedure. So they requested the PREVAIL trial, which was really powered mostly for safety endpoints. And we can use the combination of these to get pooled data on the safety and efficacy of this device. What we know now at 5 years, this is 5-year data pooled from both of those trials, is that the way I phrase it with patients is that this is a roughly equivalent therapy compared to warfarin. All these have been randomized to warfarin in terms at reducing stroke. So it's not better than warfarin. It doesn't eliminate the risk of stroke. It's comparable to reducing stroke when compared to warfarin. Most of that is driven by the reduction in hemorrhagic stroke. There is a trend towards increase in ischemic stroke in the Watchman patients. But one of the key things is that the strokes in patients with a Watchman tend to be smaller. We know that strokes from AFib in general are large cortical emboli that result in debilitating strokes. After a Watchman device, they tend to be smaller strokes when they do happen. One of the unexpected things that we've seen in the 3.5-year data and now the 5-year data is that Watchman is associated with a decrease in all-cause mortality, a 27% absolute risk reduction in all-cause mortality compared to warfarin. And so there aren't a lot of things out there that have that sort of mortality reduction. This was statistically significant both at the 3.5-year data point and the 5-year data point. And I think it's something to discuss with patients that there is a mortality decrease. And these curves you can see are diverging. So we think the longer that the patient is off anticoagulation, the more benefit they receive from the Watchman therapy. If we were to try to drill down and identify patients that would benefit most from this therapy, I think if we were to take a casual approach, we would say that it would be patients who are at high risk of stroke, high risk of bleeding, don't want to be on a blood thinner, have had some sort of bleeding event. But none of the trials included patients like that. All of the trials randomized patients to either warfarin or Watchman, and by definition, the patients had to be warfarin tolerant. So I think that looking at this data in that light is important. In fact, the higher risk patients, patients with a CHADS Vas Score of 4 or more, may actually not benefit as much as patients with a relatively lower risk of stroke. I think it makes sense that patients with an elevated Has-Blood score have a lower risk of stroke. But we are probably underusing this technology because of the general approach that our field has taken in reserving it for patients who are at high risk of bleeding or have had some sort of life-threatening bleed. The other important thing that we did not expect, but is neat to see in clinic when the patients come back, is that their quality of life when they come off anticoagulants goes way up. Patients who remain on anticoagulants, they don't like it. Their quality of life goes down, and they are elated when they find out that they can come off anticoagulation. If we're talking about dollars, which we need to talk about in today's world, this is Medicare data looking at a 10-year mathematical model using Medicare dollars. And in these graphs, you want to be down in the bottom right corner, which is more effective and less expensive. You want to avoid the top left corner, which is less effective and more expensive. And you can see that left atrial appendage compared to warfarin after 10 years in Medicare patients is more effective and less expensive in most patients. The same is true when compared to the benevolent anticoagulants. And so that in patients who can benefit from this therapy for more than a few years, we think that it's a cost-effective strategy. And there are other models that have had similar findings in this. So switching gears for the last couple of slides, one of the things that we see in patients with pacemakers, and we're now seeing a lot more in patients with wearable devices that can record atrial fibrillation, is patients are surprised to find arrhythmias. In particular, patients with AFib, we know the minute that they go into AFib, and we can record exactly how long they're in AFib. And there's some data that somewhere around the 5 to 6 minute mark of silent AFib, asymptomatic AFib detected by pacemakers or defibrillators, the risk of stroke goes up. You can change this timeline. There's been a couple other studies that have looked at 24 hours, which has a more prominent increase in risk. But even at 5 or 6 minutes, the rate of stroke goes up. Our strategy here at New Mexico Heart is to use somewhere around the 5 to 6 minute mark as a cutoff for AFib. And that's in patients without prior stroke. If someone's had a previous stroke, we may be a little bit more conservative and even go down to 1 minute or less. We see a lot of patients where we're doing the inverse. So the patient has had a stroke, they've never been diagnosed with AFib, and we suspect that they may have AFib as the cause of their stroke, particularly if it's an embolic stroke to the cortex. And there are a couple strategies that we use to try to identify AFib because it does influence the stroke prevention strategy that you use with that patient. The traditional way in the past has been some sort of remote monitor, like a 30-day monitor. I would say a Holter monitor for 24 hours plays almost no role in this situation. And I think a 2-week or 30-day monitor plays a limited role because of its limited time frame of monitoring. We have these new devices available. These are the 3 models on the market. They're relatively small devices that are inserted subcutaneously. It takes about 5 minutes. The batteries last somewhere in the 2 to 4 year range. And they all have algorithms that are specifically designed to detect atrial fibrillation. And using, in this case of this study, the Medtronic, one of the older Medtronic models, there's somewhere around a 6.5-fold increase in our ability to detect AFib in patients with prior stroke. And the other key part of this data is that the average time to detect AFib in those patients was about 8 months. So I think it's clear that a 2-week or 30-day strategy if you don't see AFib during that time, does not mean that that patient doesn't have atrial fibrillation. So in summary, any patient that you see with AFib or flutter should have a discussion about a stroke risk reduction strategy. The nuts and bolts of where that patient ends up with that strategy is the challenging part, but having that discussion is important. I think the general theme that the newer anticoagulants are more effective than warfarin needs to be emphasized, and that was relayed in the new guidelines that recommend those newer agents compared to warfarin. The left atrial appendage closure is a good option for patients who aren't ideal candidates for long-term anticoagulation, and that also made it in the new set of guidelines as a 2B recommendation. And then I just want to emphasize again that the stroke risk is really independent of the pattern of AFib. Whether or not the patient's in AFib on any given day does not predict their risk of stroke. Thank you. Are there any questions?
So in patients that have had an occult stroke who have a pending diagnosis of AFib, what is your threshold for anticoagulation prior to the diagnosis of AFib? What are the criteria you would use?
So the question was, if someone's had a stroke but not had AFib identified yet, pending that diagnosis, is it reasonable to use anticoagulation? And that's a complicated answer. There is some data using rivaroxaban and dabigatran that those do not provide a reduced chance of recurrent stroke if they haven't identified AFib. They do have an increased risk of bleeding. There is no data regarding the use of apixaban in that setting. There are some biomarkers that can be used to predict atrial fibrillation that some of the neurologists are using. I think left atrial size would be a reasonable additional marker to use. Right now, the summary of that is we don't know. Apixaban may play a role, but we don't have any data to suggest that.
What about anticoagulation preventatively in mitral disease, mitral regurgitation with left atrial dilation, or and then mitral stenosis, small mitral stenosis patients that are surgically anticoagulated?
Mitral stenosis, definitely. If you have moderate or severe mitral stenosis, those patients should be anticoagulated. I don't think we have any data for people with severe MR and no prior history of atrial fibrillation. I'm not aware of any data. So I would say right now that it wouldn't play a role.
Michael, what is the patient who has an atrial fibrillation and has remained in sinus rhythm, what is your feeling about stopping anticoagulation?
So the question is, what do we do for patients who have had a rhythm control strategy like ablation, and how do we address stroke prevention in those patients? That's a good example of a shared decision-making process. The guidelines state that it's a class 1 recommendation that you continue anticoagulation based on their CHADS Vas Score, regardless of the perceived success or failure of the ablation. So there are some trials looking at that question, but right now, the guidelines say you anticoagulate based on their CHADS Vas Score, not based on the success of an ablation. There are certainly patients that we pursue some long-term monitoring strategy where we can modify that after discussion with them, but that is a little bit outside of the guidelines. Of course, the guidelines are guidelines, but I think the overall theme would be to continue anticoagulation.
Thank you.
We have another question here.
I had actually, that was one part of my question was cessation after atrial fibrillation. So you see a lot of people who have had that done. I guess that's not much guideline. The other scenario I was wondering about was the same thing with you had a surgical
Sure. So the question is about anticoagulation after a surgical left atrial appendage closure of any type. And one of the things that we've seen with surgical closures is that they're closing these appendages when patients are on bypass or they're under anesthesia, and doing it from the outside, often from the outside of the heart. And so looking at those closure sites afterwards is important. So somewhere after the 6-week range, our recommendation is to reevaluate the anatomy of that closure. Is there a thrombus associated with it? Is there a large vestibule associated with it? We've seen patients where there's a full appendage after closure. And so I think some sort of imaging, either CT or transesophageal echo, is important.
Or clip as well.
Clip as well. Any type, I think it's fair to look. The anatomy of the appendage from the outside of the heart is way different from the inside of the heart. And that ostium can be really funny looking. And the result that you get from an epicardial clip may not translate to a perfect endocardial result.
I have a question. It was a Watchman case I was involved in my previous practice. So right before we were about to do the Watchman, had like a dense smoke, really, really dense. What would you do in that case? Would you proceed or not?
Yeah, so the question is, what do you do in the case of dense smoke or echo contrast? That is associated with a risk of stroke. Yeah. It's not physiologic thrombus. Right. So most of the time, unless there's actual thrombus, you could probably safely proceed.
Okay.
In that
so we
case.
Did that. We actually gave Definity just to make sure there was nothing obvious. They gave 5,000 heparin and we proceeded, but unfortunately the patient did have a stroke. Yeah. So I was just curious if that was the right thing to do, or you know. Well,
I think one of the other questions in patients like that is, will you feel safe in the future stopping anticoagulation, sure, even with a perfect result? If their atrial velocities are such that the whole atrium is filled with smoke, yeah, it would make me nervous after the fact stopping.
Which then begs the question, why proceed with the Watchman, I guess?
Yeah, I think that's a reasonable question, and it depends on the patient situation.
Yeah.
Hey, Mike.
Mike, I was going to say, could you say something about post-surgical AFib monitoring and anticoagulation?
Referring to surgery in particular, or ablation, or?
Yeah, post-cardiac surgery.
Well, we know that the rate of stroke and AFib is higher after cardiac surgery of any kind. We know that when you have AFib after cardiac surgery, your mortality goes up. So there is some data with, in particular with mitral valve surgery, using some sort of long-term monitor like a loop recorder to look for AFib. I don't think we have any data to preemptively anticoagulate those patients. When someone has post-operative AFib and they have not had previous AFib, the standard of care is typically somewhere around 4 to 6 weeks of anticoagulation with then some sort of monitoring afterwards to see if the AFib is gone.
So usually what we've seen in our practice though is that the patient gets put on amiodarone and comes and sees the general cardiologist a month later without anticoagulation. So should we be changing that thing?
Yeah, I think if you have post-op AFib, they should be anticoagulated. There's pretty good.
Usually I've noticed that they use amiodarone, patient's sinus rhythm, so now you kind of like stuck like, okay, we have amio on, but we don't have anticoagulation on, so what do we do next at that point?
Yeah, I mean, there's a lot of questions in that question. I think short-term amiodarone is certainly appropriate for post-operative AFib and probably the preferred approach as a general practice. I think that the safest data-based decision overall would be to anticoagulate patients with post-operative AFib. There are certainly confounders to that decision in someone who's had heart surgery, but all things being equal, if they can tolerate anticoagulation, they should probably be anticoagulated for at least 4 to 6 weeks. in general, you can stop the amiodarone at that point.
Was that looked at in the popular trial? Did they anticoagulate those patients on any? Or?
I don't know that. I'm not familiar with the name of that trial.
That's the post-op amio trial that defined what we're doing with amio.
Yeah, well, there's an antiarrhythmic effect, but there's several series that have shown that postoperative AFib is associated with stroke if they're not anticoagulated. I don't know if that was looked at in that particular trial. And those patients have a higher mortality.
Are you referring to the AHIS trial?
No, he was. Mark was asking about the popular trial.
Papa Bear
trial. And I don't know the details of that trial. So.
Hey, Mike, this is Brendan. Great job. That was a great review. I have a question about folks that are stuck on Coumadin, whether it be for mechanical heart valves or cost. It looks like the data shows that people that have wildly swinging INR levels, both on the high end for bleeding is a problem, but also on the low end for stroke risk. What's your comment about some centers using fixed dosed vitamin K to sort of blunt extraneous influences from diet when using warfarin on those people?
I can't comment because I'm not real familiar with that data.
Okay. It's intuitively, it seems like a reasonable idea if someone is really particularly like a mechanical mitral valve, but I don't know if there's any actual randomized data. It seems like these centers are using it as a sort of an ad hoc type of database for their own patients.
Yeah, I'm not familiar with that data. That's an interesting concept. Unfortunately, the newer agents, dabigatran was looked at with mechanical valves, and that trial was stopped early because of increased mortality. So that's a class 3 recommendation. The other ones didn't even bother because I think the thought was that they were so likely to fail. I think one of the other interesting questions is randomized data regarding left atrial appendage closure versus the newer anticoagulants, which to this point we don't have. There is a trial going on right now looking at the newer generation Watchman device, which has some engineering advantages to the older device that has been used to this point, and comparing that newer device to Eliquis. It's called the Champion trial, and everyone's eagerly awaiting those results to put that question to rest, because Eliquis may end up being superior to left atrial appendage closure. So the question was, what do you do if you need to cardiovert a patient in AFib who has missed a dose of their anticoagulant? And I think the risk of stroke is pretty small. Okay. And if you think it's otherwise clinically reasonable, I mean, you can always make your cutoff of safety wherever you want, but it has to be a reasonable cutoff. And you could argue to do TEs on everybody, but the data doesn't suggest that. I think that missing a dose here and there probably has a minimal impact on the risk of thrombus formation.
Is there any clinical significance to the hypercoagulability that is present in initiation of warfarin or in cessation of the NOACs?
The question is the thrombophilic effects of starting warfarin or coming on and off the newer anticoagulants. We don't think, there is a statistical blip in particular the Rocket AF trial, which is the rivaroxaban trial, that those patients when coming off their Xarelto for some procedure or something had a statistical increase in the rate of stroke. And the real world experience has not been consistent with that. We think that that's probably a phenomenon of just high risk patients in a clinical trial coming off their treatment arm. They're going to have a higher event rate. Daniel's comment was about surgical closure and the fact that databases that have the surgeons here routinely, regardless of the technique used, evaluate the appendage with PE off bypass at the end of the case to document the absence of the appendage. That is, and then probably the question not clinically is that a long-term effect? One of the things that we've unfortunately learned, there is some with the Watchman biochemical evidence that patients are slightly more prothrombotic in the first couple of days of the way it looks, therapy, but immediately post-procedure is often not the way it looks 6 or 8 weeks down the road. And why that is, we don't really understand. But the Lariat device, I think, is a reasonable analogous approach to surgical closure where you're removing the appendage. And our initial experience with that device was that we would have perfectly flush atrial wall, no leak, no communication. And then there would be a vestibule that comes up 3 months later with some sort of either remodeling or whatever is happening, but to the point where we had to change the technical approach for that device. So I think that it's probably worth the inconvenience to image those patients, but I agree with you, there isn't any data.
And the best imaging is CT or to detect the leak?
Well, vestibule. A vestibule can be seen with either CT or transesophageal echo. The leak can, the CT is going to be, pardon? Yeah, the CT is probably more sensitive at detecting leaks. But I agree with you, Daniel, it's an unknown thing.
Technically, again, I'm just a clinician. I think that there are no pretty large studies, no mechanism for the key. The only time a key could fail, you can put it over into the base and jump down in the gap. Sometimes they say the base of the appendage, which is a very hostile environment with the surface right there.
Yeah.
And my partner can cut it out. There's no, the appendage doesn't grow back.
Yeah, I hear what you're saying. I think that we have looked at a few cases where it's not as, it just doesn't look like we would anticipate it looking.
I think it's really important to consider cases.
Yeah.
So from surgeon QA point of view,
ligated but not excised.
Ligated is a different case. Ligation has a very high rate of fibrillation. Ligation is inferior to the two exceptions from my standpoint.
So for those that can't hear, we're just having an ongoing discussion about how to evaluate the left atrial appendage after surgical closure, and it seems that it's an unknown. There's a lot of unknowns there, and Daniel just made the comment that the clip or excision is superior to ligation alone, which is to be considered inferior from what I understand from your standpoint.
Ligation or some certain suture patch from the inside, which is always better than ligation of that.
But frankly, imaging before surgery may be beneficial because in the couple of failures that I have in my practice, with left atrial appendage excisions, they've had kind of these bilobar left atrial appendages, and one lobe was actually excised and left basically.
I had one just last week and put a clip on. And I do not see the full extension of probably the major part of the left atrial appendage. And I took a second loop a minute later, and I figured out the state. I took the new one. But that's something that's very visible on the post bypass PE in any of our physiology.
Okay, well, thanks, guys. I appreciate everyone attending.
Thank you.
Appreciate that.